This is the Roscoe's Wetsuit Neuro Podcast, the neurohacking show where we teach you how to optimize your cognition. Keep up to date at roscoeswetsuitneuro.com. Now here's your host, Toby Passman.
All right, we have a special guest on the show with us today, Dr. Ken Starr. Dr. Starr is board certified in emergency medicine and addiction medicine. He's an authority in the field of addiction medicine and wellness. Since founding the clinic in 2012, after the overdose death of his brother, Dr. Starr has been committed to helping patients achieve lasting sobriety and improve the quality of their lives. Dr. Starr utilizes medications, supplements, traditional and non-traditional therapies that help people overcome chemical dependency and live the lives they know are possible. His current areas of interest include advancing drug and alcohol detox methods, facilitating long-term recovery, IV nutrition programs for optimal health, and men's health programs. Dr. Starr's passion about NAD therapy has enabled the clinic to become the most experienced provider of NAD treatments on the West Coast. So Dr. Starr, super excited to have you on the show with us today.
Hey, thanks, Toby. Great to be here, and thanks so much for having me.
So tell me a little about your story in terms of, as I briefly alluded to in the bio, it sounds like the death of your brother seemed to kind of be the genesis of all of this sort of happening. Is that fair to say?
Yeah, I had trained in emergency medicine. I finished my training in 2000. I was in your neck of the woods. I was in Eugene, Oregon for the first 10 years of my practice doing full-time emergency medicine and, fire and EMS and, medical director and paramedic training and all that kind of stuff. Moved to California in 2010. And at that point, around 2010, 2011, I started to kind of get, just a little tired of emergency medicine. I was very interested in addiction medicine because a good friend of mine is an addiction psychiatrist in Portland. And he had talked to me just all about work he was doing with, medication-assisted treatment and buprenorphine. And I really kind of was drawn to that. And I liked it and it sounded good. And so I started playing with that idea, like, well, maybe I should do something with addiction medicine. Then my brother, who had a lifelong history of substance abuse problems, overdosed and died in 2011. And I felt like that was my calling, like, wow, this is affecting everybody. And then it was almost like, how like when you see an ant, all of a sudden you see one ant and then you look and you're like, oh my God, there's millions of ants, That's how addiction medicine was for me. So I kind of used that as a catapult. I started to do some more training and eventually got board certified in addiction medicine. But as I started offering substance abuse treatment, I realized that, wow, this is affecting everybody. And so the clinic just blew up. And over the years, we've just gotten bigger and bigger and bigger and affected more lives. And it was just a good timing. I mean, at that point where I live in San Luis Obispo, there wasn't a lot of options, right? There was sort of a county program. If you were mandated because of probation or you had Medi-Cal or something like that, or there's luxurious 5-star, $2,000 a day overlooking the beach rehabs that California is known for. But what about just drug and alcohol programs for everyday people that are outpatient, where they can get counseling, medication support, and get treatment and live life on life's terms, right? We're not just throwing you on in a rehab for 30 days. It's like, outpatient. So I just got interested in that and started doing that and continued to work emergency medicine. But over the years, every year it would just be like one less ER shift a year, a month per year, and then more clinic days. And actually, as of July, I retired from emergency medicine just earlier this summer and just do the clinic now full time. So so my brother's death was really important in letting me commit to that practice. And I felt like, if we had the services back then that we have now, maybe his outcome would have been different.
So in terms of talking about what's going on kind of in the brain with addiction, what's going awry that is, leading people to kind of end up, throwing away their lives or just risking so much to continue using whatever substances or alcohol what kind of brain changes are taking place there?
Well, I probably couldn't give you a satisfactory explanation from the neurobiology level that you're probably used to, but it's clearly a dopamine reward system that's gone awry, right? For lots of different reasons, partly because of maybe upbringing or trauma or emotional distress. People are more vulnerable, but probably there's a genetic component, because we know addiction happens to just every people, no matter what. You can have a great family, a great upbringing, and become an addict. And you could obviously have a lot of trauma, neglect, abuse, abandonment, and maybe you're more prone to addiction. So it's the simple answer. It's your dopamine reward system that's really become out of control, and that positive reinforcement found in substances quickly turns to negative reinforcement, and I can explain that if you want, where such that then people who have been using anything for a while will just tell you they're just using to feel normal, right? Not to get high or to check out, or just to feel normal, right? Because the neuroadaptations can take place so quickly. We see that clearly, most commonly with alcohol and opiates, but I think benzos and we've talked about this offline, but benzos, I've had patients who take benzos for a week, and I've spent years trying to get off of it. So everyone has their sort of their sensitivity and their vulnerabilities to these medicines. And for a lot of people, that first drink or that first pain pill is just like that big warm hug that they have always wanted and felt like they needed. And that's not the typical normal response, but it's a very real response. And then that's just kind of the beginning of the conditioning and the neuroplasticity that goes on to affect that sort of reward system.
Got it. So when it comes to treating addictions, you use a lot of NAD to treat addiction. Can you tell me a bit about just, and the listeners a little about what NAD is and how you got introduced to it?
Sure. Yeah, great story. So I was just doing drug and alcohol treatment in San Luis, and standard kind of medications, counseling. I wouldn't say we had any sort of novel approach or anything alternative or different. Then they had a patient, Toby, who said that he was going to go to Louisiana and do brain restoration therapy for his addiction. And of course, at that time, I'm just super skeptical. I'm just, thinking, yeah, whatever, go ahead, go do your fairy dust on your head and come back. Well, I followed up with this guy, at some point later, and he was great. He was doing fine. Like, really? Oh yeah, no, I'm off. No cravings. I've been sober for 6 months. And okay, well, now what is this called? Where did you go? And then I got curious. Like, okay, well, this is something might be here. So I found out about Richard Médier, who was in Springfield, Louisiana, at the Springfield Wellness Program. And I started talking to him, and I said, hey, well, how do I do this? He's like, well, you need to come out here and you need to learn how to do NAD. It's not like I'm just going to tell you in a minute on the phone. So I took my one vacation that year, and I went down to Springfield. I think in the heat of the summer, if I remember right, it was like humid and nasty. I was like, oh my God. But what I saw really changed my life. I mean, I saw patients detoxing in their program off of alcohol, off of opiates, off of high dose opiates, who are doing amazing. Like, I had not seen that before. I'd never seen anybody, day 4, day 5, kicking methadone, who's relaxed, hanging out, reading a book, eating lunch, feeling fine. I mean, these patients are, shitting themselves in the corner, right? This is not a good experience. And these people are doing great. Well, I did a week there or so, and I just remember flying back to California and just having this vision. It's like, this is going to change the face of substance abuse recovery nationally. I mean, this is the new standard. What I saw NAD infusions do to reduce withdrawal and craving, I thought, I'm bringing this to the West Coast. This is unbelievable. So we started our NAD program back, I want to say around 2014. So what is that, 7 years ago maybe? And that's how we started with NAD. So so NAD is nicotinamide adenine dinucleotide. It is a a vitamin. It's a coenzyme of the B vitamins, but you can't just take NAD by, you can't just increase your NAD by taking niacin, which is a big misconception. You can't do that. But anyway, if you give IV NAD, and people figured this out back in the 50s, there's articles back in the 50s where we knew that if you gave NAD to patients, and the original study actually came out of Seattle, that it reduced all cravings and withdrawal from people who are detoxing, and not just detoxing off alcohol, which is probably the most robust response, but barbiturates and stimulants and sedatives. And for some reason, I'm not sure, it fell out of favor. I think probably because methadone came into the picture and was much more profitable for centers. But we started our NAD program, and and that was pretty early. Now everybody's offering NAD, right? Every infusion clinic and wellness practice and IV therapy center in the mall. I mean, everybody will do NAD. Now, that's really for a wellness indication. They're just doing it for longevity and to feel good and to feel better. And it does do that, but it's a little bit more complicated for withdrawal and detox, but that's kind of our expertise, and that's been my interest. So now we still offer NAD. I think it actually ends up being kind of a small part of our program now. I think most of our substance abuse patients don't do NAD just because the time and the cost is kind of restrictive for a lot of people. But I love it, and I do it when I can. And I think those patients, turn around faster, have a better, they just get feeling better faster is really the way to explain it. When people ask you, like, well, explain what it is. What I say, Toby, is like, look, if you stopped using pain pills right now, okay, a year from now, you're going to be fine. Okay, your brain will recover and you'll be okay. But it's going to be a rough few months, right? There's acute withdrawal, which you know what that is. But then there's post-acute withdrawal, right? We're just fatigued and you don't have any energy and you have a lot of anxiety because your brain really hasn't started making that sort of neuroprotective soup, the normal amount of endorphins and enkephalins you need to feel good, right? To feel motivated, to get out of bed, to want to go do stuff, to hang out with your friends, to go work out, right? You need a certain amount of dopamine and endorphins in your system, which are not there, right? So, and that's why the relapse rate's so high, right? You take people, they'll go through detox, they'll get a week or two behind them, they feel like they've got this, but they feel horrible for months. They just depressed and anxious and don't want to do anything. And then they just take that one pill one time and boom, they feel great. It's right back where they started. And that's the cycle of addiction. Well, what NAD can get you feeling like that year, how you're going to be a year out, I can get you feeling like that, a month out with NAD. It really just provides this sort of rapid restoration. I wish I understood all of the molecular biology of how it works. I mean, I certainly can explain how NAD is involved in alcohol metabolism, because you can just Google alcohol metabolism, look at a picture, and you can see that you burn up all your NAD metabolizing alcohol. But any of this, all these substances really induce a lot of stress on your central nervous system that deplete your NAD. And NAD is just pivotally involved in over 400 systems: your immune function, your aging, your sleep, your stress response. I mean, everything is just dependent on your nervous system working optimally, and NAD is just such a core component of that. So when you deplete people of NAD, they're just really not doing well, right? Their cravings are high. And there's studies, and I can link to it, but there's studies now that show that if you give NAD, people have less cravings for drugs. So anyway, that was my interest in NAD, and I'm a big believer in NAD. I've become a little bit more selective, about the patients now over the years, as I've seen people do better on some things than others. But so that's kind of my experience with NAD. Is I found out about it from a patient who did it, and I just learned from them, and then got interested. And then as I've been in the space longer, I've actually, just connected with people all over the country now. On NAD, there's been 2 or 3 conferences nationally on NAD for practitioners of NAD. I think more people are familiar with it now. There's a nurse in Monterey who just has a wellness practice, and she does way more NAD than I do, but she's just giving it for wellness and anti-aging and, feel good and feel better and that kind of stuff. And she does 10 times more NAD than me. But we have people coming for longer programs to, detox off opiates, to detox off. When traditional therapy hasn't helped, I think there's a role for NAD. I love the alcohol response is my favorite. My alcohol patients, they always just respond really wonderfully and predictably to NAD. So that's probably my favorite patients to give NAD to. But there's a role for other things. And of course, we use it for neurocognitive impairment, neurocognitive decline, Parkinson's, Alzheimer's, real kind of mixed success. I don't try to overpromise it, but neuropathic pain, a lot of like facial pain, migraines, there's been a role for NAD. Trigeminal neuralgia, we've had surprising results with that. Interstitial cystitis, just kind of like when your nervous system gets mixed messages, right? I mean, it just kind of gets the chronic improper, the chronic stimulation just kind of results in an improper signal generation if it's that stress response there's too long. So, you know, there's been NAD used for regional pain syndromes and complex reflex sympathetic dystrophy. So it's really, I mean, the most simple way is it's just like a central nervous system mitochondrial tonic, right? It's just things, you know, people report, wow, my vision's better, my hearing's better. Wow, okay, well, that's cool. That wasn't what you came in for, but that's good to know. So yeah, we love NAD, and for a while, that was really the majority of our practice. As we've kind of grown now into more of a wellness practice, it's not the biggest part of our practice anymore, but we still get a lot of NAD patients and a lot of interest in NAD. I just think we have a reputation now for really being knowledgeable about NAD. So, but as it's become more available and accessible, I think that, you know, people aren't really coming in from all over the country as much as they used to, because there are NAD providers now in their cities or their states that are probably closer, which I respect. I want to make it easy and as possible and as accessible as possible. So that's a little quick, kind of a quickie on NAD and what it is and how I started using it.
And you were mentioning a bit about the dopaminergic system being a bit faulty when it comes to addictions. Do we know if NAD is involved in dopamine metabolism? Is it affecting that dopamine system at all?
You know, it must be. I think there, well, yes, it does. How, I'm not sure. I know that there is actually an alcohol metabolite that binds NAD that affects the reward system. I remember seeing something about that when I was reviewing literature, you know, a couple years ago. It's definitely cooling down the stress pathways. And I think that there's actually evidence that NAD has some dopamine binding, if I recall, you know, correctly. I wish I would have prepared better for that question, but I think there is evidence that NAD directly affects the reward system, because you see that clinically, right? So in other words, there was a study that came out of Springfield that was presented at the Academy of Neurosciences meeting in DC about 10 years ago, where they looked at cravings in the substance abuse treatment program. And they had what you normally see is, as people go, you know, day after day after day after day in a treatment program, cravings increase normally, right? And they showed, compared to control, that cravings decreased in all the self-reported scores in people who got NAD. Every day people got NAD, as far as 10 days out, they had less and less and less and less cravings. And people who didn't get NAD had more and more and more and more cravings, right? Which is, again, why relapse is so high. So it is affecting reward in the dopamine system, you know, in some way. And there's a lot that we don't know. I know that Ross Grant, who's a big NAD researcher down in Australia, one of the probably the leading researcher of NAD in the world, he talked and he said there's mechanisms of NAD that we don't understand, and we don't even know how it really gets into the cell. The Chromadex people with the nicotinamide riboside guy, I can't remember Richard, can't remember his name. He says, well, you can give NAD, but you're not doing anything with NAD because it's too big to get into the cell. It has to be degraded into its precursors, its metabolites like NMN, nicotinamide mononucleotide, and NR, nicotinamide riboside, to be integrated into the cell to work. And he basically poo-poos any IV NADs, like your snake oil cells, and for giving IV NAD. And I've heard other people, pretty knowledgeable people, also kind of mention that. But Ross Grant, who has no skin in the game, I mean, he's just an NAD scientist, he's in cell NAD. He has proof that there's NAD uptake systems, that there's systems that uptake NAD right into the cell. They haven't been defined or characterized, and that's what his lab is doing in Australia now. But he has experiments that show, no, there is a way that NAD is getting to the cell without being broken down. It's not too large of a protein. So there's some contention in that field. And I've been at the conferences where these researchers all debate each other. It's a little bit over my head, but look at, I give NAD and it makes a huge difference in people right away. So I think it works. I don't know the cell signaling pathway and the uptake, protein mechanism to probably explain it to your more scientific crowd. But, I think for supplementing though, I think there's absolutely a role. I actually prefer, and you're probably the first person I've told this to, I actually prefer giving like oral nicotinamide riboside or oral MNN as a precursor to people rather than just giving sublingual NAD or nasal spray NAD. I think I feel personally more of a benefit when I do that. And, but I know there's a following, lots of people like the nasal spray NAD or the sublingual NAD. But like I take nicotinamide riboside more than I take regular NAD because I just feel like it has more of an effect on me. So there's lots of ways to skin a cat, but I think at the end of the day, NAD ends up being a very important modulator in wellness and longevity and in health span, right? And my angle has always been substance abuse and recovery, and that's how I've gotten interested in it. But clearly, the vast majority of people now even coming into the clinic aren't even coming in for substance abuse treatment. They're coming in for NAD programs, for mindfulness, for wellness. We have a big transcendental meditation group of women that comes in and does NAD. They feel like it really boosts their kind of awareness and sensitivity. So I'm fascinated by it. I learn more and more all the time. There's a paper that came out that said your NAD level is probably your biggest predictor of dying from COVID, right? I mean, people who are unhealthy or hypertensive or obese or diabetic or older all have in common low NAD levels. And there's a paper, again, I could find it and send it to you, where it said that's probably supplementing with NAD is probably preventative for that. I thought that was interesting. So yeah, so it pretty clearly has cognitive improvement. It clearly has helpfulness with withdrawal and craving, which is my passion. So I don't know. We've treated hundreds of patients right over the last, 7 years now, 6-7 years. So we're blessed and grateful to do it. I think it's a game changer, and it's a good alternative because so many people have tried everything else. Lots of patients have been off of, opiates or off of benzos for months and months and months, and they just have very protracted withdrawal. I think that's a great role for NAD. I love giving those people 5-7 days of NAD when they've done everything right, they've kicked it, but they're suffering. And we've had people been off of benzos for a year come in and do NAD because of post-acute withdrawal. Again, things that most people don't have any believability for, right? Most doctors will say you're full of shit if you tell me you DC'd your Valium a year ago and you feel like you're still on withdrawal. I just don't think most doctors are going to give that credence, but it's absolutely a case. I get emails from people every day from all over the country telling me about their battle with, trying to regain normalcy in a post-opiate or post-benzo state. And they didn't just jump off yesterday. I mean, these people have been off of meds for years sometimes. So yeah, so I don't know. I'm fascinated by it. We love doing it, and it's an interesting area to work.
Now, besides NAD, what are some of your other favorite sort of treatment modalities that you use in your clinic?
Well, I think our other favorite treatment modality is ketamine. The other things that we just have a general IV infusion practice as well. So, high dose vitamin C and minerals and vitamins and electrolytes and so forth. I think that there's a lot of people with just such poor and shitty nutrition and chronic stress that just giving them like a Myers cocktail a couple times a week, results in just a major improvement in their mood and their stress levels and in their health. But ketamine is probably the other interesting infusion that we have. And I got interested in that because I had already been using ketamine in the ER for 20 years. I mean, I've been using ketamine all the time, right, for pediatric injuries and sedation and so forth. So I was super comfortable and familiar with it. And then as this literature came out about how effective it was for treatment-resistant mood disorders like unipolar bipolar depression, treatment-resistant anxiety, PTSD. I thought, well, that's interesting. And we were already doing infusions. I mean, I already had a nurse here. We're already doing infusions. I already had this familiarity with ketamine. Like, well, let's start doing ketamine. So then we opened up the ketamine center, which is really just an added service to our wellness group. And we've been doing that for a few years. It really didn't get busy until probably this year. It's kind of kicked up a lot, probably post-pandemic. But ketamine has just a very anxiolytic effect, and improves depression and relieves anxiety for a lot of people when you do these, these infusions. So that's been a big game changer and added to our arsenal of mental health treatment as well. I think we're still the only ketamine program on the entire Central Coast. I'm surprised there aren't more. I mean, I think it's easy. I think it's safe. I think it's effective. So yeah, so ketamine is a big part of our program here too.
And now with ketamine, is it mainly just the mental health patients that you're treating with ketamine, or do you find any efficacy with like treating substance abuse and rehabilitation?
Yeah, that's a good question. For the most part, we're using just the standard National Institute of Mental Health protocols for mental health treatment. So the vast majority of patients are depression and anxiety that just hasn't responded to first or second line treatments. That's the majority. The other thing is, yes, ketamine has been shown to have a role in detox and recovery. And there was a paper that showed that ketamine has a role in preventing alcohol relapse and alcohol cravings. Again, probably by just really working as a strong NMDA receptor antagonist and decreasing glutamate, which is excitatory. So that I have used it in opiate and alcohol withdrawal, as well as more prolonged recovery. Yes, I have used it for that. And then there's pain protocols too, which are different. That's higher doses for a longer duration of time. So for perspective, a depression or anxiety treatment is typically like 40 minutes. That's kind of what the standard is. We'll maybe draw it up to an hour for some reasons, but the pain protocols are double the dose over like anywhere from 2 to 4 hours. I'm not a real big salesman on using ketamine for pain. I've had a few patients that had dramatic and lasting improvements in chronic pain from ketamine, but most people don't. I mean, that's just my personal opinion. And when it does help, it doesn't last that long. So it kind of depends on the experience. I mean, I had a guy who really had a miraculous response just a few weeks ago that blew me away. But a lot of times, like when I was using ketamine in the hospital for pain, by the time they were checking out, their pain was back. So I wasn't like a big believer in it, but these higher doses for longer periods of time certainly have a role. I think it depends on the type of pain. So the way I explain it is, if you have a mechanical cause for your pain, ketamine is not the treatment, right? If your knee hurts because you have degenerative arthritis in your knee, ketamine's not going to do anything. But when you have your central nervous system is just hypersensitive because of a regional pain syndrome, again, typically this is, CRPS or fibromyalgia, or a similar pathway, or maybe chronic back pain that now functionally is just chronically inflamed and an area of sensitivity. I've seen ketamine help that quite a bit. So honestly, all those patients who are coming in for that, they've tried everything else already. I mean, they're not people who are like naive to the healthcare system. These are patients who have been to neurologists that have had pain pumps or stimulators, or they've tried every single medication out there, and now this is their last alternative. Like, yeah, I heard about this. My doctor told me about this. And then these are the guys like, my God, why didn't I do this 10 years ago? Holy shit, you serious? Okay, this is great. So, and if it works, that's great. And then maybe we'll just do a booster every month or every 6 months, or everyone's different. The durability, as we've talked about, is the most unpredictable thing. Like, say we do ketamine and it works great. Well, how long does that last, right? Is it going to last 3 weeks? as it can last 3 months. And that is really just a wild card. I have a psychiatrist who comes in for a ketamine infusion once a year. He comes in once a year. He's like, this holds me all year. It's just amazing. No, sorry. He comes in twice a year. He comes in every 6 months. And I thought, wow, okay, well, I mean, you would know. He's just a local psychiatrist. He knows the stuff. And I think that's the exception. I think most people end up coming in probably every 6 weeks for maybe a little booster. But if it works great, but only lasts a week, I mean, you can do ketamine every single week. I don't know how practical that is, just in time and money and so forth. So it's an individual decision. But I think there's a lot of information on ketamine out there on the internet and research. So it's clearly a lot more mainstream than NAD. If you start Googling, and researching NAD in patient, you're just not going to find much. There's not much published. There's a handful of stuff, but it's not really good randomized, quality, double-blind, placebo-controlled stuff. A lot of it's, I don't know, a lot of it's sort of people selling ketamine. I mean, like, for example, Springfield Wellness Center, who's by far the most experienced ketamine program in the world. They were involved in a lot of the research, and it's good research. I mean, they've brought in external scientists to help design the research protocols and so forth. But I don't know. They're in the business of selling NAD. So
now, when it comes to ketamine, I interviewed an anesthesiologist who uses ketamine in his practice in LA, Dr. David Majubi, a few episodes ago, and he was discussing in terms of the way people are benefiting in terms of their mental health symptoms. He was saying he thought it was like a 60-40 balance in terms of, I believe it was 60%, the just sort of neurochemical biological effects of ketamine. And then he thought 40% of it is the actual kind of experience that ketamine produces that is therapeutic for a lot of patients. I just wanted to kind of run that by you and hear your take as far as, people who are really improving with ketamine. Do you feel like it is just something that the chemical is doing, or is it facilitating some sort of mystical, spiritual sort of experiences that are improving people's symptoms?
I think he's right. I mean, studies have shown that ketamine does work by producing changes in the brain, reversing neural damage caused by stress and depression, and decreasing inflammation and cortisol levels. But certainly part of it is the mystical experience. Part of it is definitely ego losing realizations that help put your history and problems in a different perspective and allow your brain sort of to change the channel on what it determines as reality, right? So a lot of our stuff is just the same ruminated, stupid thoughts that we just continually have over and over and over and over and over again, right? We have these self-limiting beliefs and these circuits of whatever that creates your reality, right? Of what your history is, or what you're capable of, or who you are, or whatever. Well, ketamine can just change that channel. Like, wow, now I know why I'm depressed, or wow, now I have a different outlook. So it physiologically absolutely affects the brain. There are chemical changes in the brain and neuronal and dendritic growth and so forth. You're definitely shutting down glutamate, but there's absolutely part of that mystical experience in neuroplasticity that affects it. We started recently doing ketamine assisted therapy, right? So the first couple of years we did ketamine, it was just like, you're going to do your 6 sessions. You can kind of debrief later with your counselor or psychiatrist. And more recently, we've integrated, a couple of therapists who are very experienced in guiding people in ketamine. Now we actually switched to doing more of an oral ketamine in that situation because they're in a different setting than the office. But having the guided journey, I think, again, depends on why you're doing it, right? But if it's for depression or anxiety, I think that's really a well worth added value to help someone kind of help you navigate, a therapist to help you navigate that. So, I don't know if it's 60-40 or 70-30, but clearly there's physiological changes that happen in the brain that have been measured, and photon microscopy has showed that dendritic neural growth and cool stuff like that. You can find those pictures, but clearly there's like the mystical experience, and there's people who just describe just the lifting of their depression. Just the water is not as deep, the problems aren't as heavy, everything, the sun's a little bit brighter, like things are just lighter. And then if nothing else, it just puts them in touch with a way, wow, I don't have to be depressed, I can feel better. Maybe that's part of the system too. So yeah, I think that that's not unfair to say that. I don't know if it's accurate, but it seems pretty reasonable. There's definitely a spiritual journey that goes into the ketamine experience that I think it opens doors for people, as well as real physiological antidepressant changes that affect your central nervous system. Yeah.
So you mentioned about the ketamine assisted psychotherapy. It brings to mind, it seems like MDMA assisted psychotherapy, maybe psilocybin assisted psychotherapy, or treatment modalities that seem to be getting kind of fast tracked and seem to be ones that are going to be available for people, at least that I've seen in the research for like PTSD specifically. Are you planning on integrating any of those treatments ever into your practice in the future?
Oh yeah, absolutely. As soon as I can legally do it, and as soon as there's some recognized sort of treatment protocols that we can safely and with some evidence bring to people, absolutely, yeah. I think the whole serotonergic model of depression is inaccurate. Not to say it's not helpful for some people, but doesn't explain much. And even the American Psychiatric Association, after the publishing of that book, Anatomy of an Epidemic, had to come out and say, yeah, we really don't know much about depression in SSRIs, and we agreed that there's a lot more to the story. So yeah, NMDA and the mescaline derivatives and PCP derivatives like ketamine, which was actually invented as an alternative to PCP, all are going to have a major role in mental health, and the future of mental health is absolutely involves psychedelic therapy.
So
yes.
for people listening, there might be a bit of confusion as far as, with mental health conditions. There's often this comorbidity of substance abuse, and we've talked about, how some of these different substances are really messing with people's lives. So how is it that, some of these other substances like ketamine, MDMA, psilocybin, why are these things showing real significant improvements for people's mental health, whereas some of these other, drugs and alcohol seem to really be destroying it?
Well, the psychedelic modalities don't stimulate dopamine release, so they're not really addictive, physiologically addictive, right? So for something to be addictive, it's got to have a dopamine surge, like meth, like opiates, like alcohol in people. Psychedelics don't do that. They don't work on that system. So there's not an addiction, a physiological addiction to NMDA or to ketamine. So I think that any lasting treatment of substance use has to address people's underlying vulnerabilities, right? And connections, and you have to understand the tools of recovery, and understand what your triggers are, and understand what your shit is. Okay, sorry, but you just have to understand what your shit is. And psychedelics can give you a fast-tracked way to understanding why you believe what you believe, and why that may not be true, right? So what else is going to do that? I mean, it's well known now that you can do psychedelic therapy, and it can be more effective than years and years of therapy. because you're changing your consciousness to receive information outside of what you're willing to or knowingly able to filter.
Now, in terms of, your experience just in addiction medicine, what are some of the most common misconceptions that people have about substance abuse or addiction?
Well, that's a good question. I mean, it's a medical problem, right? So if you're, say you have uncontrolled asthma and you're stealing other people's inhalers and you're using your kid's nebulizer, I mean, it's like you're addicted to albuterol. Okay, you're like, wow, you're really misusing this. You have an uncontrolled, you have uncontrolled asthma. Well, if someone has an opiate addiction and they have behaviors that result in them needing to satisfy that addiction, I mean, that's where medication-assisted treatment comes in, right? Just as you're going to use a long-acting inhaled steroid to control asthma and minimize albuterol use, you could use a long-acting opiate like buprenorphine or methadone to control opiate addiction. So I think that the thing I would want to say is that addiction affects everybody. Like I say, we've had people from all walks of life have substance abuse issues. There's a lot of stigma around it, unfortunately. I think that we need to be much more mainstream and make the treatment of addiction easier and more accessible, less expensive, just more available. For example, buprenorphine, which is the standard of care now for opiate use disorder, most primary care physicians are not waivered and are not prescribing it, right? There's still treatment programs that are not supportive of using buprenorphine in an opiate recovery program, even though all the evidence suggests and that the risk of overdosing and dying is reduced 80% if you're on the medication-assisted treatment program. Your risk of relapsing is reduced significantly. Your chance of staying in recovery are much longer if you're on medications for addiction. So, yeah, it's just people, just the shame and the guilt that with addiction are obviously more real and present than other chronic medical problems, right? I mean, if your testes started hurting you, you probably wouldn't talk to all your friends about how your nuts are bothering you, but it could be something serious, right? Like maybe you should get that checked out. Maybe you need an ultrasound. Maybe you have testicular cancer. I mean, but you don't because I just, it's just achy. I sat on my bike wrong, or I spent too much time, running. I don't know. But one of my goals, Toby, was to destigmatize addiction. And that's why the clinic is really the wellness group, right? That's why the name of my clinic is the wellness group. It's not just the addiction medicine group or the addiction treatment house or something. That's why I have, groups. I have a nutritionist. I have therapists. I have wellness infusions. That's why we do other things too, right? When we do some men's health, we do some just, high dose vitamin C. We help work with cancer patients. I mean, we all have something we need to improve on. We all have something that a health concern that we need to optimize. So whether that's losing weight or whether that's, doing something else, it's like there's so many things that affect us. Addiction is just one of them. But when people come in here, they're like, wow, this is pretty nice for a drug treatment program. Like, what are you expecting? Like a bunk, concrete room and a bunk? You deserve that because that's what you deserve, right? No, it's like, let's talk about it, let's address it, and let's treat it. Now, I don't want to pretend like medication is the only treatment for addiction. I mean, I think medication's 10% of the treatment for addiction. I think 90% is, counseling and support and groups and programming and accountability and working your stuff out. But my point is that I think that it's been nice that, opiate use treatment, which is, obviously most of what we do, and alcohol use treatment is a little bit more recognized. I think it's okay now to be in recovery. I don't think you need to hide that from your friends as much, or if you're drinking non-alcoholic beer, or if you're not, partying, people are good with it. So I think that times are shifting a little bit. And I think more and more treatment is available. I mean, you know, my background's emergency medicine, and you know, at least from that perspective, a lot of these treatments, like, you know, a lot of these medicines we use now are now available in emergency departments, which wasn't the case even just a few years ago. So I think that's a win. So, like, if we can just if we can just destigmatize it, make it more accessible, then I think that would be a good first step.
Well, that's good. It sounds like things are moving in the right direction there. In terms of, I've seen research as far as, in states where, cannabis is legal, decreases in like opioid related deaths. I just wanted to hear your take on cannabis, since, people, I guess, use it to replace other maybe more addictive drugs, but even though it is, at least psychologically, could be addictive in its own respect. Now, when it comes to, addiction, what's your take on the cannabinoids, CBD, THC, and what role they play?
Well, I certainly have seen some very serious health and mental health problems from cannabis use, specifically young people getting into high THC concentrates that have caused significant psychosis and mental health problems. I think that's the exception, though. You know, the cannabinoid system is very useful and helpful. I think that the vast majority of people who are using cannabis do so in a very reasonable way, even if it's all just recreational. I don't really have a problem with it. You know, I mean, like it's like it's not a problem till it's a problem, right? I mean, having a drink or two a week, having a beer once or twice a week is not a problem, right? If you're smoking weed all day, it's probably causing problems you're not aware of. You know, if you're having a little 5 milligram or 10 milligram edible at night to help you sleep, there's probably not a big problem with that. You know, so addiction is defined as really a compulsive use of something in association with negative consequences. So can cannabis be a problematic and cause problems and result in some addiction? Yeah. Is it a gateway drug? No, it's not. Is it safe? Yes. Are there really good medical indications for using cannabis and THC? Yes. Are there really good health indications for abusing fentanyl? No, probably not. So in where I practice in California, marijuana is legal. So every patient's on, cannabis. So it's not, I've never had, well, that's not true. I've had maybe 1 or 2 patients in 10 years of doing addiction medicine come in just for cannabis abuse. It just doesn't cause the destruction that alcohol abuse and opiate abuse and other things cause. So, so it's kind of tricky. It's really dependent on the individual. Like my wife uses a THC CBD cream for pain. That's great. We have CBD products in the office that are great for inflammation and anxiety. We actually use them in our detox program. I think they have very little to no THC in it. But yeah, I'm supportive of it. I'm actually, I guess, pretty pro cannabis in general. But being an addiction medicine specialist, I kind of have to be tame about my response to that. I think it causes more good than harm for sure. Yeah.
Well, Dr. Starr, we're coming up onto the end of the show here.
Yeah. Right.
Any closing thoughts, anything that we haven't covered yet in our discussion of addiction or mental health treatment that you feel like would be important to leave the listeners with?
No, just I'm always mindful to talk about addiction real respectively, because if I'm in a room, even in like an educational environment, probably 25% of people in that room have an active substance use problem. Maybe they're abusing Ambien, or maybe they're drinking cough syrup, or maybe they're drinking alcohol too much. I mean, so this is really just a widespread issue, and just nice to kind of just help people get help. And it just takes so much. Just forgive yourself and move forward. The windshield's always bigger than the rearview mirror for a reason. So it's just a good, I'm happy there's more treatment. I'm happy there's more accessibility to treatment. I think health providers are more aware of substance use problems now than they were in the past. So no, but thanks for what you do, and thanks for having this interesting podcast and having me on as a guest.
Of course, of course. And if people want to find out more about your clinic, where would you direct them to?
Well, we have a YouTube channel called Starr MD Wellness, which I would love to have more subscribers. So send out a link to that. We have a website. It's just kenstarrmd.com, which lists our just kind of general clinic information, of course. The website, the YouTube channel has a lot of information, and a lot of questions answered, and a lot of topics that we discuss. And then we have a supplement program where we actually sell some specific supplements like the NAD and so forth. And that's called getcleansupplements.com. Getcleansupplements.com. So that's something that we've put together too. So yeah, we kind of got our hands in a few things.
Awesome. Awesome. Well, I encourage you guys to go check that out. And for the listeners who enjoyed the show, go ahead and like and subscribe to our YouTube channel, Roscoe's Wetsuit Neuro. And you can also subscribe on whatever audio platform that you listen to the podcast on, whether that be Spotify, Apple Podcasts, or any of the other major platforms. We are on them all. Dr. Starr, I wanted to really thank you for coming on the show today and sharing all of your knowledge and expertise.
Well, thanks, Toby. Thanks again for having me. I sure appreciate it.
Of course.